morning and hello everyone. I'm Lieutenant General Velu Nair, who retired from the Armed Forces Medical Services in 2017, and I'm presently employed as the Chief Consultant in Haematology and Bone Marrow Transplantation with Apollo Cancer Center in Apollo Hospitals, Ahmedabad. Today, ladies and gentlemen, is the 8th of May 2025, which happens to be the World Thalassemia Day, a very important day to celebrate and honor all our thalassaemic patients and also to express gratitude to the clinician, healthcare professionals, the transfusion medicine specialists and blood banks, the scientists working in research, and numerous NGOs and the central and state governments for their tireless, dedicated efforts for making the lives of our thalassaemic patients better. Beta thalassemia major is the commonest of the thalassaemic syndromes in India, and it's a genetic disorder of the blood which is passed down by asymptomatic carrier patients to their child, especially when both the parents are carriers. There is a 25% chance of the child being born with a major thalassaemic syndrome called as thalassemia major. The problem here is it's a lifelong disease. They are dependent on blood transfusions from birth till they are alive, which is a huge challenge because they've got a lot of associated complications, which I will come to a little later. India is the thalassaemic capital of the world, with over 40 to 50 million carriers which exist amongst our population. And there are 10 to 15,000 newborn fresh cases of thalassemia major in our country. And this accounts for 10% of the global incidence. And what is worse, most of these people, if they're not supported properly with high quality blood transfusions and supportive care, they will die by the age of 20 years. We also know that these thalassaemic syndromes are more common in certain ethnic races, especially in our country amongst the Gujaratis in the Kutch region, the Punjabis, the Bengalis, and certain Muslim groups besides the tribal populations from Odisha, Gujarat, Maharashtra, Madhya Pradesh, and parts of Karnataka. The only curative treatment today is bone marrow transplantation, which is costly, not easily accessible, and the biggest challenge is to have a donor. The chance of finding a healthy non-disease bearing donor within a family is only 25% among the siblings. And from the registries, even it's actually more difficult, especially in our country, because we don't have a large registry. Now we are doing half-match transplants, which is much more challenging and can have more morbidity, mortality, but definitely it's more costly. So transplantation, though offers a cure, it's limited in its availability. So what else can we do for these patients? We can give them high quality blood transfusions, making sure that they're all screened very well. And also with each transfusion, the iron load in the body increases. And ultimately, the iron becomes to such a high degree that it starts affecting the endocrine system from the pituitary to the other endocrine glands, the heart, the liver, and many other organs. And when these children grow and become adolescents, they don't develop their secondary sexual characters, which becomes a stigma. They are stunted in growth, their facial bony structure gets distorted, they have dental issues. So they have a whole lot of other collateral problems which develop as they grow. So these patients require regular screening and addressing these health issues, whether it's endocrine, bone health, organ systems, and regular screening for iron overload by ferritin, blood iron levels, and also T2 star of the liver and the heart. So in the management, supportive care becomes paramount. And in this, besides blood transfusions, offering iron chelation therapy and support for the same is so very important. with regular monitorings. So here comes in the challenges and the gaps. The challenge in the gaps, number one, is creating awareness amongst the general public, amongst the policy makers, decision makers, both at the state and central level. And also, of course, the family and their parents and their relatives. This is very, very important because all these people also, when they grow up, they get married. So they have to be counseled. If two carriers get married, they have to be counseled that there are chances of thalassemia major child being born. So obviously, genetic counseling becomes very, very important, and the state must offer these things free of charge. Now, the other gap is, having enough trained manpower for doing all these jobs that I told you, whether it's monitoring, whether it's creating awareness. So we need a whole band of people who actually deliver these various services to the community. And also to make this disease a notifiable with registries to tell us what is the data on the number of people who are being born with this disease every year, and also the ones who are alive, what is their lifespan, what are the problems they face. So all this comes only when you have a registry, which is obviously at a national level. And I think that's something which we still need to do. Now, I'll tell you, there are a lot of thalassemic societies which are very active, which are need-based. In over 15 states, there are over 30 societies doing human work. They do free services, get them to camps, get doctors to see them, and get financial support. So is many NGOs very active. Also, many people, corporates are indulging in corporate social responsibility, CSR work. For example, we have Coal India supporting for transplant. Likewise, I must say that the government has also made a lot of initiatives in this, from the Ministry of Health and Family Planning and also from the Ministry of Tribal Affairs. And, agencies like ICMR, DBT, DST, they all support these projects. So I think it's very important to also know that various states support thalassemic programs in different ways. In the state of Gujarat, transfusions are free. They are given a lot of supportive services in a free way, help for iron chelation. When we do bone marrow transplantation, there's a Chief Minister Fund which gives liberally, financial help for these patients. And to make it even more easier, even center the Prime Minister's Fund from the PMO, there is help being given for transplant all over the country. So I think we have done a lot of work in the last few decades, but there are lots more to be done in form of unmet needs, which I just elaborated. And I think we must take this up on a priority as a preventive strategy to prevent the occurrence of births of thalassemic children in our country is so important. For that, the medical fraternity, the lay public, the decision makers, the policy makers, all of them must come together. And one such birth which is prevented is a huge help to the society, because it's a big economic burden not only for the family but for the state and the center. So I think also the medical way to screen, to pick up thal majors by antenatal tests, and to offer, even if need be, medical termination of pregnancy are all modalities we need to develop and offer in all parts of the country. And then I would like to say that one often neglected part is vaccinations. All these children who are transfused regularly must be robustly following a vaccination program, starting with hepatitis B. So hepatitis B is so preventable, and we know that the frequency of hepatitis C and B in these children is higher than the lay public. So I think we must take all actions that they are vaccinated against the available vaccines, and also put in the national program and free of cost. So ladies and gentlemen, in the last 30 years, there's been scientific advances in the prevention and management of thalassemia syndromes, which has resulted in an impressive increase in the survival and the improvement of the quality of lives of these patients. So let's all pledge today to refocus and rededicate ourselves to looking after these thalassaemic patients and their families and to make sure that they get the very best. Thank you very much. Jai Hind.